Hello, everybody. Today we'll discuss together some cases with end-stage disease with some internal medicine issues. As weekly, we discuss hematology cases. So we'll start today with some cases like complicated end-stage renal disease with some problem solving. So we'll go for that. We'll start with this case. We have here 50-year-old male with chronic kidney disease, seen and follow up after diagnosis of bilateral DVTs. He has a history of 15 pack year smoking history, having quit 20 years ago. So our question today about which of the following is appropriate cancer screening. As you know, in Canada, we do some guidelines for cancer screening. In this case, we have a patient with chronic kidney disease, and we have bilateral DVTs. So as you see here, the right diagnosis or the right choose here like FIT. Let's go first for cancer associated VTE and mostly in Canadian guidelines. So we'll see here some cancer with very high risk, like brain, stomach, pancreas, and high risk, like lung, lymphoma, gynae, bladder, testicular, myeloma, and renal. And some case with like blood work during, when you go for some blood work about some patient, you'll find like maybe platelet high or hemoglobin low, or using of erythropoietin stimulating agents, or YBC is very high, or BMI very high. This is like cancer, and some cases during management of cancer, you feel like you have to go for DVT prophylaxis. As per Canadian guidelines, clinical practice guidelines recommends considering DVT prophylaxis, apixaban 2.5 BID, or apixaban 10 once daily, or low molecular heparin for high risk ambulatory cancer patient as is a score like 2 or more. So if you have a brain cancer, stomach cancer, pancreas cancer, or high risk with like platelet more than 350, or hemoglobin less than 100, or the patient already in erythropoietin stim agent, or pre-chemo YPC is high, or BMI. So maybe high risk cancer, or very high risk cancer, or high risk cancer with other points in blood work or BMI. So in our question here, we didn't find brain or even very high or high risk. We didn't find in this point like brain or stomach or pancreas. So just the question like routine workup in patient 50 years old on smoking history for 15 pack per year and quit 20 years ago. So let's go for Canadian guidelines again. We have here like cancer associated with VTE. Like as I said, 2 points, we need to go for prophylaxis. As apixaban 2.5 PID or apixaban 10 once daily or limited. So let's go for a review of Canadian guidelines about cancer. You'll find here, don't screen for these cancer like melanoma, testicular, ovarian, prostate, esophageal, even with chronic GERD, chronic gastroesophageal reflux disease. If the patient with chronic gastroesophageal reflux disease hasn't any alarm symptoms, so no need for screen for cancer esophagus. You can look here to doesn't apply to patient with alarm symptoms. So we can screen for esophageal cancer for dysphagia, adenophagia, weight loss, anemia, bleeding, loss of appetite, and doesn't apply to patient with previously diagnosed Barrett esophagus. So the Canadian guidelines for cancer don't go for a screen in MOTPE, MOTPE, melanoma, or ovarian, testicular, prostate, esophageal. So we can go for esophageal and some alarm signs. So don't screen in like gender cancer, like except breast cancer, like testicular or prostate in male, or ovarian in female. And don't screen for melanoma. And don't screen for esophageal, except there are alarm symptoms as dysphagia, adenophagia, weight loss, anemia, bleed, or loss of appetite. For colorectal cancer, we have to screen in colorectal cancer. In all patient Canadian guys or girls from 50 to 74, not recommend over 75. Method of screening like maybe FIT, we'll go for FIT right now and discuss it in details, every 2 years. Or flex sigmoidoscope every 10 years. But don't use colonoscopy. No need for colonoscopy if the patient like just a screen and average risk, no alarm sign for cancer colon. But every Canadian guy from 50 years old to 74 years old, you have to go for a screen of colorectal cancer. But for MOTPE, as I said, melanoma, ovarian, testicular, prostate, esophageal without alarm signs, or Barrett esophagus, no need for a screen. But for cancer colon, after 50. So if we have increased risk, like first degree relative, one or more than one, with colon cancer or advanced adenoma, the time of screen is different. The age of screen is different. So like 40, maybe, or 10 years before earliest age of relatives diagnosis. What does it mean? Like if we have a patient with brother has colorectal cancer. The diagnosis of brother cancer was like when he was 6 years old. So you have to screen his brother like 10 years before this diagnosis, like 50. If this guy diagnosed with cancer colon like 50, screen his brother and his relative 10 years before the age of diagnosis, like 40, and so on. And there's different method for diagnose or screen. The screen here, it depends mainly on colonoscopy every 5 years. So if the patient refusing that, he said, no, I can't go for colonoscopy, it's invasive and no need and something like that. So you can go for FIT, but it's like yearly, every year, to screen that. Maybe there's different guidelines, but in summary, for NOTSB, no need for screen, melanoma, ovarian, testicular, prostate, and esophageal without alarm signs or bad esophagus. But you have to screen for cancer colon, every Canadian guys, as per Canadian guidelines, at the age of 50 to 74 with FIT. It's a simple immune test for test in stool. For high risk, which has adenoma before or has family history, first relative, one or more, you can go for like yearly screen, like 10 years before his relative, and you can go for different method like colonoscopy. If he or she or they refusing for colonoscopy, you can go for FIT, but every year. For lung cancer, we can go for three. You can first screen lung cancer in 3 criteria. Like we need 3 conditions, like conditions to be screened. Age, the same 55 to 74, different, 55. And more than 30 pack per year as smoking history. And current smoker or quit within past 15 years. And the method of the screening is like low dose CT every year. Don't use it chest X-ray or sputum cytology. You know? So we can go for our patient here. Our patient here is 50. So he lost the first criteria for screening of lung cancer because we need 55. And 15 back year. And we need, as you see here, we need 30 back year. And he quit. He did quit, 20 years ago. And we need quit here like less than 15 years. So we can't screen this guy for lung cancer. For HCC, hepatocellular carcinoma. So you look here for Canadian guidelines or Canadian guys. All patients with cirrhosis, regardless of age and etiology, and stuff like that. But there is some exception for cirrhosis. A child C cirrhosis, because it's advanced like cirrhosis, so no benefit from, maybe it's the same mortality, I feel that. Or a child C, you can screen for cancer if the patient is transplant candidate or life-limiting comorbidity, so he will get benefit from HCC screening. The second patient in Canada for screening about HCC, endemic country like Asia with hepatitis B surface antigen positive. For Asia, you need male more than 40 and female more than 50, 40 or more or 50 or more. For African or North American Black, more than 20 years. But I mean all patients with hepatitis B surface antigen positive. And something like endemic country like Asia, more than or equal 40 in males and 15 females, and African or North America more than 20 years old. Or family history of HCC in first degree relative start age 40, or HIV co-infected start at age 40, or hepatitis D co-infected patient at any age. What's the method of a screen? Like ultrasound, Q6 months, and some guidelines like American, they screen by AFP using alpha-fetoprotein plus ultrasound. As our patient today, he didn't find, didn't find indication for screening of HCC because our patient 50 and no hepatitis B, surface antigen positive, no history of cirrhosis, so no need for screening of hepatocellular carcinoma. So our patient is indicated for colorectal cancer screen. As average risk or high risk, as average risk, so we'll go for FIT. What's FIT? It's like simple test, stool test. It's called fecal immunochemical test. Safe, painless test. Show like check stool for tiny amounts of blood. So you can go after FIT for colonoscopy and more screen for colorectal cancer. So it's very, very simple test. So our patient is in need for FIT in this question. The second question today about male patient, 70-year-old, chronic kidney disease, on low molecular weight heparin after diagnosis of DVT. He then presents a hospital with facial nerve lesion, and CT scan of the brain reveals 2 centimeter mass with surrounding vasogenic edema, which was following is the most appropriate next treatment. We have a patient on dialysis, and he got DVT and start low molecular heparin and came with facial nerve lesion. And we did CT scan for the brain, and we find, as you see here, like vasogenic edema. Canadian guidelines go for some treatment for that cases if you have intraparenchymal lesion causing vasogenic edema or something blockade of CSF flow, maybe second is from breast lung melanoma. But the patient came with, this case is the patient will come with vertigo, ataxia, headache, vision changes, or neurological deficit. Management, first of all, we need urgent MRI brain and leptomeningeal disease. We need urgent MRI brain and full spine. But we can get this patient dexamethasone 10 milligram IV 1 dose, and then dexamethasone 4 milligram per oral IV QID, and then consult. So for our patient here for relief of, brain cancer, as I said, is highly risk for DVT. Brain, and as I said, pancreas and stomach. Highly risk. So the patient got DVT, and we start low molecular heparin, and finally we find METs or find like vasogenic edema because the patient came with facial nerve lesion. So what's your treatment? What's your next treatment? I said. So the most accurate next treatment here to go for dexamethasone, like as I said before, 10 milligram IV, and then go for 4 milligram QID just for relief of edema, and consult or even ask for MRI and search for seconds, maybe breast, maybe lung, maybe melanoma, and so on. Third question about patient with AKI. During examination, we find bilateral iliofemoral DVTs. He has lab tests that show homoaptoglobin less than 0.01 and LDH elevated and hemoglobin 90 with normal INR and PTT, and there is hemosiderin in urine, and you need to go for diagnosis. It's like renal case. We have an acute kidney injury with this patient, no clearness about age or gender, but just we have DVT, we have thrombosis. We have thrombosis with hemolysis. So we have LDH high. It means hemolysis. And we have consume of haptoglobin, which means we have here intravascular hemolysis. But INR and PTT normal, which mean no evidence for like liver disease or DIC. And we still have hemosiderin in urine, which means we have intravascular hemolysis. So we can go for differential diagnosis. In cases with intravascular hemolysis, we have G6PD deficiency, we have autoimmune hemolytic anemia, mechanical hemolysis, some drugs, and PNH. Why we will go for diagnosis and searching about PNH? Because we have the thrombosis. So the accurate here for diagnosis, PNH. How can you investigate PNH? So I can start with flow cytometry. So flow cytometry, like searching for CD or cluster differentiation. As you see here, deficiency in PNH4, CD55. So paroxysmal nocturnal hemoglobinuria, it's clonal stem cell disorders, bone marrow failure. There is mainly intravascular hemolysis and some extravascular hemolysis, and we have uncontrolled complement activation, plus thrombosis, venous or arterial. And the common site for that is splenic and hepatic. So we'll find thrombosis in a typical location, anemia, hemolysis, hemosiderin or red urine, So we have to go for blood flow cytometry for diagnosis of PNH. There is loss of CD55 and CD59. In some cases, you will find out pancytopenia, what's called overlap. But there is, I feel it's very important, this point. We have in some cases erectile dysfunction, because you'll find decrease in nitric oxide. So you'll find pulmonary hypertension and erectile dysfunction, which is very important. And the therapy here, like anticoagulate if thrombosis events, no rule for primary prophylactic anticoagulant, just there are thrombosis events like I have here DVT. And the main therapy is complement inhibitors, because we have very active complement 5. So they like ocrelizumab, decrease hemolysis, and maybe the patient need transfusion that's like symptomatic. If the hemoglobin like below than 70, you can go for blood transfusion. We discussed today 3 cases, which is very important from some patient with chronic kidney disease or renal disease, like patient with screening of cancer, patient with hemolysis and DVT, and patient with vasogenic edema. Next episode, we'll go for more and more cases with medical issue and interstitial disease. So